So good day to all of you. I'm happy to meet you all in yet another interesting recall session of the NEET 2025 examination. So I'm Dr. Jamuna Shaktish, your faculty mentor for pathology from Dopamine. So we'll quickly have the recap of all the questions. So this year we had 4 questions from hematology followed by genitourinary, and we had 3 back-to-back interesting questions in autoimmunity. In the lymph node granuloma, see granuloma always we have 1 question. This year we had 2 questions. Genetics we had 2 questions, and always as we keep on insisting, 1 question from pedigree analysis was there. And cell injury, endocrine thyroid, always medullary carcinoma, hemodynamics and joint pathology. So these were the questions in pathology, and all these questions were discussed in our channel. So we'll go to the questions one by one. So this is our first question. Which of the following cell death involves activation of caspase enzyme? So you're all aware that caspase enzymes are the enzymes involved in apoptosis, isn't it? So apoptosis, we have the caspase enzymes. And what else other than apoptosis? See, necrosis. So necrosis is caspase independent. So we are all aware. So it is not necrosis. And this entity, what is this necroptosis? So necroptosis is, as the term says, necrosis with apoptosis. It is caspase independent programmed cell death. So that is the terminology for necroptosis. So we have only one option that is left, that is apoptosis and pyroptosis. So which is the right response here? So we'll have a quick recap. So we all know that what is necrosis here. What is the first change that will happen in necrosis is cell membrane lysis. So there is a lysis of the cell membrane. And in apoptosis, there are 2 pathways. We have the intrinsic pathway, which is dependent on the mitochondria, and we have the extrinsic pathway. So intrinsic pathway involves caspase 8. Extrinsic pathway involves the caspases 9 and 10, and they all merge to have the common pathway. So in the common pathway, we have caspases 3 and 6. A quick recap on the pro-apoptotic, anti-apoptotic genes. So we have the pro-apoptotic genes. So what are they? That is the BAX and BAC. So they are the pro-apoptotic genes. Anti-apoptotic, they are BCL2, MCL1, BCL-XL. Regulated apoptotic initiators which will cause initiation of apoptosis. So what are they? So they are the BAX, BAD, BIM, Noxa, FUMA. So these are all the entities which we should have to be aware of. Coming to the special types of apoptosis, we have necroptosis. As I already said, it is caspase independent programmed cell death. Pyroptosis, so it involves pyroptosis. Pyro means fever, involving interleukin-1, which is the pyrogen, inflammatory cytokine. So this interleukin-1 will specifically activate caspase-1. So here again, it is a caspase-dependent cell death. Ferroptosis, so ferroptosis is iron-mediated. We are all aware. So the right response for this question is apoptosis and pyroptosis. We'll move on to the next question. So we have a 68-year-old man presenting with bleeding manifestations. Peripheral smear showed this characteristic cell. So what is this cell? As you can see here, this is a large cell. So we have a large cell. We have a prominent nucleolus. So this is the nucleolus. And in the cytoplasm, you have something like this. So just like a bundle. So that particular cytoplasm, that is called as a fagot bodies. So fagot bodies are classically seen in AML M3. The characteristic translocation in AML M3 is 15-17 translocation. That is a PML RARA translocation, which we have discussed so many times. So what about other translocations? So what is this 821 translocation, which is classically seen in AML M2? And 15-17 in AML M3. 14-18, our favorite follicular lymphoma. Inversion 16 is associated with AML M4 and M5. Anything, whenever we have a myelomonocytic differentiation, whenever we have the monocytes, for example, in AML M4, myelomonocytic leukemia, or AML M5, the pure monocytic leukemia, we have inversion 16. So here, the right response is 15-17 translocation. Okay, again, much more. So what is this particular thing? So this is the Oyer rod, which is very classically seen in AML M2. And this appearance, so this is a 5 body, which is again, when it is round in shape, you call that as pi body. When it is linear, you call that as Oyer rod. So these two classic signs are seen in AML M2. And this fagot cell, as we have discussed, is a characteristic feature of AML M3. Okay, so we'll move on to the next question. A lymphoma characterized by the presence of centrocytes and centroblasts with BCL2 positivity and CD10 expression. We have discussed it so many times. So the classic BCL2 with CD10 expression is the characteristic feature of follicular lymphoma. What is the translocation involved in follicular lymphoma? It is 14-18 translocation. Okay, so this is a very straightforward question again. And what are the translocations? What about the other translocations? What is this 2-5 for? It is anaplastic large cell lymphoma. And what is this 8-14? Our favorite Burkitt lymphoma. 14-18 is follicular lymphoma. And this 11-14 is mantle cell lymphoma or multiple myeloma. Will have this classic translocation. So please make a note of this, very, very important. CD10 positivity seen only in follicular lymphoma. Very clear. Coming to hairy cell leukemia, as I always say, remember the hair like this. So it is 11. CD11 along with one 3-digit number, that is CD1 or 3. So when this is there, it is hairy cell leukemia. So follicular lymphoma done, hairy cell leukemia done. Coming to mantle cell and CLL, both will have CD5 positivity in addition to CD20 positivity. So which we have to remember. Okay. So follicular lymphoma characteristic CD10, hairy cell leukemia, remember CD11 with one 3-digit number, CD103 positivity. So the next question, a classic question, very tall man. So whenever we deal with a tall man, yes, thing which comes to our mind is Marfan syndrome, found to have ectopia lentis. See, remember, whenever the person is having a bilateral ectopia lentis, we have only one diagnosis, that is Marfan syndrome. So here the question is slightly twisted. Which gene is most likely to be defective? So what is the gene in Marfan syndrome? It is FBN1 gene. So very straightforward question. So this question is, what is the genetic alteration in Marfan syndrome? So they have just slightly twisted this question. I'm sure that all of you would have got it right. So something to do with Marfan syndrome. So what is the mode of inheritance of Marfan syndrome? It is autosomal dominant. And what is the gene involved in Marfan syndrome? What are the organs involved? What is the classic sign? Life-threatening complication of Marfan syndrome, and what is the criteria? So coming to the gene involved in Marfan syndrome, it is 15q. What are the organs involved? It is, as the picture says, see, people with Marfan syndrome will have a more skin elasticity. So it will involve the skin. We said bilateral ectopia lentis, so it will involve the eye, and the most dreaded complication involving the cardiovascular system. The classic sign seen in Marfan syndrome is bilateral ectopia lentis, as we have already discussed. The life-threatening complication is aortic incompetence, so which in turn lead on to aortic dissection. So because of aortic dissection, the mortality is high in Marfan syndrome. And what is the diagnostic criteria? It is called as you're all aware, it is the Gens criteria for Marfan syndrome. Okay. So the next question, another simple, straightforward question only. A 30-year man presented with a painless testicular mass. So whenever we use the term painless mass, we are looking at a germ cell tumor. Ultrasound shows a well-circumscribed, homogeneous, non-hemorrhagic. See, remember the keyword. Homogeneous means the tumor is having a same color across and there is no areas of hemorrhage. So whenever homogeneous, non-hemorrhagic is given, the most likely diagnosis, even without seeing the histopathology image, is seminoma. Okay. So all the other tumors, yolk sac tumor and choriocarcinoma, so they are all heterogeneous with areas of hemorrhage. Teratoma means we'll have hair, teeth, pultaceous material, all those things will be there inside the cyst. So here, without even looking at the histopathology, it is seminoma. So what do we see in the histopathology image? As you can see here, you have a well-defined cell membrane. Well-defined cell membrane is there. And you can see a clear cytoplasm, isn't it? So a clear cytoplasm, a round nucleus, round or oval nucleus with the prominent nucleolus. Okay, so this is the classic description of a cell in seminoma. And what is more important is the seminoma cells are arranged in lobules and the septa will have a lymphocytic inflammation. So lymphocytic infiltration will be there. So which is a classic feature of seminoma testis. The tumor cells are arranged in lobules and the surrounding stroma, delicate septa will have a lymphocytic inflammatory infiltrate. So this is a classic appearance of a seminoma. So something to look into the seminoma. What is the most common germ cell tumor? Remember here, there is a catch. If the question is mixed germ cell tumor, usually germ cell tumors will have a combination. For example, classic seminoma with the yolk sac tumor with embryonal carcinoma, any combination is possible. Sometimes even in a single germ cell tumor, we can have many combinations like seminoma, yolk sac tumor, focus of embryonal carcinoma, all those things can be together. So if the question is most common germ cell tumor, remember it is mixed germ cell tumor. And what is the most common pure germ cell tumor? If the question is pure germ cell tumor, then it is seminoma. What is a germ cell tumor? Always in isolation. See, I said all the germ cell tumors will have combination of seminoma with embryonal carcinoma, like that combination. So one germ cell tumor which will always be seen in isolation is, here the answer is again seminoma. But remember, there are two types of seminoma. One is a classical seminoma, other is a spermatocytic seminoma. Okay. So germ cell tumor always in isolation is spermatocytic seminoma. It will not combine with other germ cell tumors. Then germ cell tumor in extra testicular sites. So we are all aware that germ cell tumor not only in the testis, it can be anywhere. It can be in the mediastinum, even it can be in the brain. So germ cell tumor in extra testicular sites. All the germ cell tumors will have extra testicular site, except which seminoma? The same response for the previous one. It is again spermatocytic seminoma, whereas all the other seminomas will have extra testicular locations, except spermatocytic seminoma. So gross, as I have already described, it is well circumscribed, homogeneous, non-hemorrhagic tumor. Microscopy, as I said, lobules of tumor cells surrounded by lymphocytic inflammatory infiltrate. Okay, since we have already discussed, we'll move on to the next question. And here, what is the immunohistochemistry marker for seminoma? So it is SOX4, OC2, NANOG. So these are all the immunohistochemistry markers used for seminoma. We'll move on to the next question. We have a patient presenting with hearing loss and balance problem. So both hearing loss and balance means you involve the eighth nerve, the vestibulocochlear nerve is involved. Histopathology shows Antony A, Antony B, and verrucate bodies. We have discussed this question so many times in our dopamine. So what is the likely diagnosis? Straightforward, without wasting time, it is schwannoma. So this is the appearance of schwannoma. So here you can see the palisading very beautifully. So here the palisading of the cells. So this is a classic appearance of the verrucate body. The cellular areas. So the cellular areas are the Antony A areas. The hypocellular areas are the Antony B areas. So what is the most common location in the cranium? It is a cerebellopontine angle. And what is the other name for this CP angle tumor? It involves a eighth nerve, so it is also called acoustic neuroma. And what is the gene that is mutated in seminoma? It is Merlin. Is a gene that is mutated in seminoma. Okay. So we'll go to the seventh question. A child presenting with visual disturbances and delayed growth. Okay. Imaging shows a suprasellar mass. Histopathology shows a wet keratin. So again, a straightforward, a suprasellar tumor with the wet keratin. These two keywords, there is only one diagnosis, that is craniopharyngioma, without any confusion. So this is the appearance of craniopharyngioma, where you see again, you see just like schwannoma, we saw verrucate body. Here also we have palisading tumor cells. So palisading tumor cells, the central star-shaped. So we use the term stellate reticulum. And inside you get, what do you call this as? Wet keratin. The soggy, wet keratin will be there. Normal keratin will be dry and flaky, isn't it? Here it will be edematous, wet keratin will be there. So a tongue-like projection of the tumor cells with palisading arrangement in the periphery, central stellate reticulum and wet keratin, which is a classic picture of craniopharyngioma. And radiologically, it will look like a cystic tumor. Inside the cyst, see this appearance. So you get this motor oil appearance, just like the crude oil appearance will be there. So that again gives a clue to craniopharyngioma. Wet keratin, stellate reticulum, motor oil appearance. So what is the site? As we have already seen here, it is the suprasellar site. And what is the origin? It arises from the Rathke cleft. What are the other terms for craniopharyngioma? So it is ameloblastoma, adamantinoma, craniopharyngioma. So these are all the other terminologies for craniopharyngioma. So the histopathology image, the motor oil appearance, it's all the same. We'll move on to the next question. So we have a 16-year-old boy presenting with jaundice and splenomegaly. The father had similar illness during adolescence. So at the same age of the boy, the father also had illness. So you can see here from the father to the son. So it's male to male is there. So probably we are dealing with the autosomal dominant disorder. And so what are the possible differential diagnosis here? Iron deficiency anemia, no, not possible. Hereditary spherocytosis, probable. Thalassemia major, again, not possible. Why thalassemia major is not possible? Because if it is thalassemia major, it will occur during infancy and early childhood. And autoimmune hemolytic anemia, again, autoimmune hemolytic anemia is not possible because autoimmune hemolytic anemia is intracorpuscular destruction, intravascular. So there will be no splenomegaly. So the possible answer for this particular question is hereditary spherocytosis. Okay. So we look into hereditary spherocytosis. As you can see, this will be the peripheral smear picture where you see the normal lymphocyte over here, and you can see the spherocytes here. And what is the treatment for hereditary spherocytosis? You are all aware, the autosomal dominant disorder with spectrin and chirin mutation deficiencies. All of them will be there. And how do you treat? You cannot treat it because it is genetic. So how do you treat the patient? You do what do you call this? Splenectomy will be done. After splenectomy, what will be the consistent peripheral smear finding? So this is a finding. So what is this thing? So this is the Howell-Jolly body. Howell-Jolly body will be seen in hereditary spherocytosis patients after splenectomy. So what are the conditions you see this Howell-Jolly bodies? Where and all you see? Whenever there is a splenic dysfunction, hyposplenism, splenectomy, then macrocytic anemia. In macrocytic anemia, because the RBCs are all very big, so within a short time as they navigate through the spleen will not have time for cleaning the RBCs. So the remnants will be remaining in the RBCs. So you get Howell-Jolly bodies. We'll move on to the next question. Which of the following laboratory techniques is most commonly used to compare and quantify CD marker? Very simple. We are all aware it is flow cytometry. So ELISA technique is used for enzymes, proteins, hormones. So here we use ELISA. Western blot, we use it for proteins. And what is the difference between ELISA and Western blot? ELISA will only quantify the proteins, whereas Western blot will have a quality of the protein as well. Any mutation or any modification can be detected using Western blot. Since we are discussing about Western blot, so what is this Northern blot used? So Northern blot is used to detect RNA. Southern blot is used to detect DNA. And flow cytometry, we know. Immunohistochemistry, we use it for tissue antigens. We'll move on to the next question. A patient presents with a mass in front of the neck. So whenever there is a mass in front of the neck, we are dealing with thyroid. with odynophagia, pain and dyspnea, pain during swallowing and difficulty in breathing. Histopathology shows tumor cells which are positive for TTF1, thyroid transcription factor 1, synaptophysin and chromogranin. So they are neuroendocrine markers. In addition, there is evidence of amyloid deposition. So very clear-cut, straightforward question, which we have discussed so many times. The diagnosis is medullary carcinoma, thyroid. So this is the histopathology appearance where you see the amyloid. And these are the tumor nests. So what is the origin? Neuroendocrine cells of the thyroid, also known as the parafollicular C cells. What are the syndromes associated with medullary carcinoma? One is MEN2, both 2A and 2B. And we have familial medullary carcinoma thyroid syndrome. What is the oncogene? Which proto-oncogene that is mutated? It is RET gene which is mutated. What is the serum marker? We are all aware it is calcitonin. So pertaining to this RET, gain of function or loss of function. So gain of function will cause medullary carcinoma thyroid. So loss of function will cause Hirschsprung's disease. Okay, another potential important MCQ. We'll move on to the next. So a patient presents with the knee joint pain with swelling. Synovial fluid reveal positive birefringent rhomboid crystals. What is the diagnosis? Again, a straightforward question without much thinking. It is pseudo gout. So in gout, the person will have a negative birefringent needle-shaped crystals will be there. So what is the crystal composition in gout? Here it is uric acid, whereas in pseudo gout it is calcium pyrophosphate. So what is the shape here? In gout it is needle-shaped, whereas in pseudo gout it is rhomboid shape. Coming to the birefringence, in gout, it is negative birefringence. Here it is positive. In gout, we are all aware what is the most commonly affected joint. It is the first great toe. So it is the first metatarsophalangeal joint is affected. In pseudo gout, it is knee joint. What is the etiology? Any condition causing hyperuricemia. Tumor lysis syndrome, remember, in patients on chemotherapy. So tumor lysis syndrome will cause. Whereas in pseudo gout, probably genetic, anything which lead on to increase in calcium, increase in iron, or decrease in magnesium can cause pseudo gout. Okay, so another very straightforward question. Whatever questions we have discussed so far are all very straightforward and simple. I'm sure all of you are correct. Yet another very simple question. What is the type of epithelium found in this lining? So it is the classical transitional epithelium. So transitional epithelium of the ureter and urinary bladder. So this is the right answer here. So as you can see here, so this is the esophageal epithelium. Here you can see the squamous cells. And here you can see the columnar cells. And whenever there is a Barrett esophagus, the squamous epithelium gets converted into columnar lining, causing esophageal adenocarcinoma, that is Barrett's esophagus. So here it is the trachea, where we get pseudo-stratified ciliated columnar epithelium. Here you have the cartilage. And this is the epithelium of the duodenum, where we see the villi and the duodenal Brennus glands. And here, as you can see here, this is the transitional epithelium of the urinary bladder and the urethra. So as you can see, the superficial, this classical cell, that is the umbrella cell. Okay, so here the right response is urinary bladder and the ureter. Yeah, so this is some twisted, slightly twisted, but an interesting question. Anti-SCL antibodies associated with. I'm pretty sure all of you know anti-SCL antibodies are seen in systemic sclerosis, but scleroderma. So the question is, anti-SCL antibody is strongly associated with what? We'll look at the options. Gastric antral vascular ectasia has nothing to do with this, so we'll rule out. All the three choices, calcinosis cutis, interstitial pulmonary fibrosis, and Raynaud's phenomenon. All these three are associated with scleroderma, especially the Crest syndrome and systemic sclerosis, interstitial pulmonary fibrosis. So what is the right response here among these three choices? We will see. So what are the types of this systemic sclerosis? We have systemic sclerosis. So that is the generalized form. The cutaneous is scleroderma. Localized form is scleroderma. Scleroderma as a part of, you're all aware, it is Crest syndrome. So what is this Crest syndrome about? It is calcinosis cutis. C, R is Raynaud's phenomenon. E is esophageal dysmotility. S is sclerodactyly. T is telangiectasia. So that is Crest syndrome. What are the antibodies associated? So the antibodies, there are two types of antibodies, remember. One is the anti-SCL antibody, other is anti-centromere antibody. Okay, so remember this anti-centromere antibody is strongly associated with this Crest syndrome. And anti-SCL antibody is associated with systemic sclerosis. The classic manifestation in systemic sclerosis is interstitial lung fibrosis. So the right response for this particular question would be interstitial pulmonary fibrosis, because calcinosis cutis and Raynaud's will have anti-centromere antibody. Okay, we'll move on to the next one. Patient presents with intensely itchy vesicular lesion. So the first keyword is itchy, extremely pruritic on the extensor surface of the elbows, knees, back, and very clearly given a history of gluten sensitive enteropathy is given. So what is the skin lesion associated with gluten sensitive enteropathy, that is celiac disease? It is Dermatitis herpetiformis. Again, see, there are so many histopathology images, but don't get panic. The history itself will give the clue. That's what I am repeatedly telling. So look at the history. There will be a lot of clues. In addition, look at the histopathology or immunohistochemistry or whatever image is given. Skin biopsy shows immunofluorescence. So this is the immunofluorescence picture. We'll see this Dermatitis herpetiformis. See, in the immunofluorescence, so this is called as the papillae. In the papillary dermis, you get IgA deposition, which is granular IgA deposition. So there'll be like dot things will be there, isn't it? So this granular IgA deposition is very classical of Dermatitis herpetiformis. We'll see the histopathology of Dermatitis herpetiformis as well. See, as you can see here, this is the epidermis. And this underneath, so this is the papillary dermis. The upper portion of the dermis is papillary dermis. So the lower portion is reticular dermis. So between this dermo-epidermal junction, okay, you get this micro abscess. So this is micro abscess. So what is there in the micro abscess? You have neutrophils and fibrin will be there in the micro abscess. Okay, so at the dermoepidermal junction, you have the basal cell vacuolization with the dermoepidermal junction micro abscess. So because of the micro abscess, what happened? The epidermis is getting detached from the dermis, as you can see here. So this is typically called as below the epidermis. So it is subepidermal blister. So that blister is causing vesicles on the skin. So this is the classical histopathology picture of Dermatitis herpetiformis. So what is the common sites? So the sites will be typically on the extensor aspect, that is on the back of the elbow. So elbow back, knees, upper back, buttock. So these are the very common areas of Dermatitis herpetiformis. The antibodies. So the antibodies are against the reticulin fibers in the skin will have antibodies against. And what is the nature of the lesion? That is a clue. It is extremely itchy. Extremely itchy. They'll have an intense itching on the back of the elbow. Okay. And what is the association? As we are already aware, it is celiac disease. And what is a direct immunofluorescence picture? So here it is IgA granular deposit. As we saw the previous picture, it is a IgA granular deposit in subepidermis, that is just below the epidermis, in the tip of the papillae. So this is Dermatitis herpetiformis. So we'll move on to the next question. Very interesting question. Which of the following conditions most likely follow the pattern of inheritance? So to understand this question, we need to know two things. One is what is the pattern of inheritance of all the choices? Then we have to look at the picture. So you know very well it is Duchenne's muscular dystrophy is X-linked recessive. Huntington's is autosomal dominant. Kearns-Sayre syndrome is mitochondrial inheritance. Marfan's, we have already discussed. We had one question previously. It is autosomal dominant. Now, after looking at these choices, we need to know what is our relevant choice there. Okay, so let us look at this analysis. So here, as you can see here, male, female. So here the female is affected. From the female, from the mother, the disease is transmitted to, see, all the entire generation. So all her offsprings are affected by the disease. So the mitochondrial DNA from the mother is transmitted to all the children, isn't it? So mitochondrial DNA is exclusively maternal. So with this simple clue, it is a mitochondrial inheritance. So what is the disease? What is the choice with mitochondrial inheritance over here? It is Kearns-Sayre syndrome. That's all. Very simple. What are the other mitochondrial inherited disorders? So we have MELAS, which is a mitochondrial encephalopathy, plus lactic acidosis, plus stroke. What is another mitochondrial inherited disorder? It is MERF, which is myoclonic epilepsy with ragged red fibers. Other diseases, Lake syndrome, Pearson syndrome, Kearns-Sayre syndrome, they are all examples of mitochondrial inheritance. So whenever a question is asked, we need to do an analysis. So this chart we have already discussed. A quick recap. If the disease is involving multiple generations, like 1, 2, 3, all the generations are involved. If the question is yes, then it is a dominant disorder. If it is skipping one generation in the middle, it is a recessive disorder. So if the inheritance is dominant, then what we need to ask is whether there is a male-to-male transmission. Okay, so if there is a male-to-male transmission, it is autosomal dominant. If not, you need to ask one more question. So what question we are going to ask? Whether there is a father-to-daughter transmission. So if there is a father-to-daughter transmission, if it is not there, it is again autosomal dominant. If it is there, it is X-linked dominant. Very simple. Okay. Then, if it is not involving multiple generation, it is skipping the generation in the middle. The grandparents are affected, the parents are not affected, then the next generation, the children are affected. If it is yes, then if it is like that, then it is recessive. In recessive, again, what we need to ask, affected people are all male. So if the answer to that question is yes, it is X-linked recessive. If not, it is autosomal recessive. So if you remember this analysis, all the questions related to that, you can definitely answer. Every time we are getting a question in this pedigree analysis. We'll move on to the next question. So we have a patient presenting with 1 month history of cough, chest pain and dyspnea, difficulty in swallowing. So imaging reveals a apical lymphadenopathy. Biopsy shows this granuloma formation. What is the diagnosis? So among the choices, we have 3 choices which have granuloma formation: TB, sarcoidosis, fungal infection. Lung cancer has nothing to do with the granuloma, so we'll rule it out. As you can see the image, you see something like this. So they are called asteroid bodies. So looking like a star, isn't it? So they are asteroid bodies. And here you see the granuloma cells. And there is no caseous necrosis. And very few lymphocytes. So all these findings point to the diagnosis of sarcoidosis. Okay, we'll see. See, this is a typical image seen in TB, where you see the central caseous necrosis. So these are all the giant cells. And as you can see here, intense inflammatory infiltrate is there, isn't it? So that is a classic granuloma which we see in TB. Whereas here in sarcoidosis, again, this is an asteroid body. And you can see the granuloma cells with a very few lymphocytes. So when there is lymphocytic cuffing is not there, so this type of granuloma, we call that as naked granuloma. No caseous necrosis, so it is non-caseating naked granuloma, which is a classic finding in sarcoidosis. In sarcoidosis, you get two bodies. One is the Sjogren body, other is the asteroid body. Asteroid body, you know, Sjogren body is actually basophilic, blue-colored concretions will be there. So that is the Sjogren bodies. Both Sjogren and asteroid bodies are classically seen in sarcoidosis. We'll move to the next question. A middle-aged female presenting with the dry eyes and dry mouth. So here is a clue: dry eyes and dry mouth. What disease we are dealing with? We are dealing with Sjogren syndrome. So further clue is laboratory test reveals positive anti-Rho SSA and anti-La SSB antibodies, which again says it is Sjogren syndrome. So the question is not the diagnosis. We know the diagnosis. So now they are asking what is the underlying pathological mechanism in Sjogren syndrome. We are all aware Sjogren syndrome is an autoimmune disorder. So obviously this hypersensitivity is not there. Hypersensitivity on one extreme, autoimmunity on other extreme. So here it is Sjogren's is autoimmune disorder. Destruction of exocrine gland by neutrophils. Neutrophils are acute inflammatory mediators, which will never be a part of autoimmunity. So this is ruled out. We look into the third choice: lymphocytic infiltration and destruction of salivary and lacrimal glands. Yes. So that is the pathogenesis in Sjogren syndrome. Deposition of amyloid in the salivary gland can occur later in any chronic inflammatory disorders, but definitely it is not the pathogenesis. So we are ruling out this choice as well. So here the diagnosis is lymphocytic infiltration and destruction of salivary and lacrimal glands. So we'll see about this Sjogren syndrome. What are the types of Sjogren syndrome? We have primary, that is the Zika syndrome. We have the secondary, which is associated with other autoimmune diseases like rheumatoid arthritis, SLE, all those things. And what is the antibody? Again, we have already discussed, it is anti-SSA and anti-SSB, antibody to the ribonucleoproteins. And very, very important here, renal manifestation. Please remember the renal manifestation of Sjogren syndrome, which is tubulointerstitial nephritis. So in patients with Sjogren syndrome, there is if the renal function is impaired, then we have to look for tubulointerstitial nephritis. Here, the glomeruli will be perfectly normal, whereas the tubules and interstitium will have an intense lymphocytic infiltration will be there, which will damage the tubules and interstitium, which is the cause of morbidity in patients with Sjogren syndrome. And progress to lymphoma, yes, because of the intense lymphoplasmacytic infiltrate, these patients can progress to B-cell lymphomas, especially to be specific, marginal zone lymphomas. So remember one other inflammatory disorder which will progress to marginal zone lymphoma is Hashimoto's thyroiditis. So that can also progress to marginal zone lymphoma. We'll move on to the 18th question. A patient presenting with the frothy sputum. See, whenever there is a frothy sputum, it means what? Pulmonary edema. Hemoptysis. Hemoptysis is because of the intraalveolar hemorrhage with paroxysmal nocturnal dyspnea. The lung biopsy shows hemosiderin-laden macrophages. So what is the other name for hemosiderin-laden macrophage? It is heart failure cells. The classic cells seen in the lung alveoli, which are hemosiderin-laden macrophages. So in which condition it cannot occur? So the question can be modified as what are all the following cause pulmonary edema except. Okay, so the choices will be volume overload, obviously will cause pulmonary edema. Right ventricular failure. Right ventricular failure cannot cause a pulmonary edema because from the lung, oxygenated blood from the lung will be taken up through the pulmonary vein into the left atrium and the left ventricle. So if there is any problem above the lung, be it in the pulmonary vein or in the left atrium or left ventricle only, we get congestion in the lung causing pulmonary edema. So obviously a right ventricular failure cannot cause. So this is the right response. The left ventricular failure will cause pulmonary edema. Pulmonary vein constriction, of course, can cause hyperalbuminemia because of decreased plasma osmotic pressure can cause a pulmonary edema. So we'll just quickly recap. Remember it, do not mug up. What are the classification of pulmonary edema? Pulmonary edema can be because of these four things: increased hydrostatic pressure, decreased plasma oncotic pressure, lymphatic obstruction, injury to the alveolar wall. All the four pathology will cause pulmonary edema. So injury to the alveolar wall, it can be because of infections, be it bacteria or severe viral infections, SARS, COVID, anything can cause, or a severe bacterial pneumonia, interstitial pneumonia, anything can injure the alveolar wall. Burns, radiation, even severe drowning, all these things can cause injury to the alveolar wall. Again, lymphatic obstruction. Lymphatic obstruction can be because of anything. Even a radiotherapy can cause a lymphatic obstruction, or infections, parasites can cause lymphatic obstruction. Coming to the other two, which are very common: increased hydrostatic pressure and decreased oncotic pressure. So what are the reasons for increased hydrostatic pressure? Volume overload. Of course, definitely, the lung will not be able to. And any pathology above the lung, as said, pulmonary vein thrombosis or pulmonary vein constriction, left ventricular failure, anything can cause an increased hydrostatic pressure in the lung parenchyma. Decrease oncotic pressure, something to do with the proteins. So anything, protein losing enteropathies. Nephrotic syndrome, where albumin is lost, nephrotic syndrome, any condition of hypoalbuminemia, even malnutrition, marasmus. So all these things, even any problem in the liver diseases, because liver is a major site of protein synthesis. So all these things can cause a pulmonary edema. Okay, if you understand the concept, you will be able to answer it. We'll move on to the next question. A patient presented with the ovarian mass that is multiloculated with the elevated CA125 more than 1000 units per ml. What is the most likely diagnosis? See, here there are four choices: serous adenoma, serous adenocarcinoma, mature teratoma, and granulosa cell tumor. See, generally a multiloculated goes with the mucinous tumor. Okay, so remember, mucinous tumors, serous tumors. So mucinous tumors are generally multiloculated. Serous tumors are generally uniloculated. A single cyst will be there. Mucinous tumors are unilateral. Serous tumors are bilateral. However, there are exceptions. So you can have interchange as well. Okay. So since if the choice of mucinous is there, I would be happy to pick up that choice. Since mucinous is not there, I would pick up serous tumor. In the serous tumor, another thing that is given is more than 1000 units per ml. More than 1000 unit, definitely we are dealing with the carcinoma. So I would pick up this choice, serous adenocarcinoma. Okay, so not serous adenoma. If it is teratoma, other findings will be there, like hair, pultaceous material, all those things will be there. The serum marker for granulosa cell tumor is inhibin. So if inhibin is given, we are dealing with granulosa cell tumor. So here the most appropriate response would be serous adenocarcinoma. So this is again a very simple question. I'm sure all of you are right. 40 years old man from a rural tropical region. So whenever they use the word tropical, we are dealing with the infectious etiology. Chronic unilateral leg swelling and skin thickening. He reports a history of recurrent fever with painful lymphadenitis in the past. So here, what is the diagnosis? It is filariasis. So what is the mechanism that explains lymphedema in this patient? Okay, lymph vessel dilatation? No, it is lymph vessel obstruction. Obstruction with fibrosis of lymphatic channel. Yes, it is the response. Direct invasion of lymphatic endothelium by the viral particle virus has nothing to do here. Hypersensitivity. See, hypersensitivity can occur because of the parasite, but that will not cause a lymphedema over here. So I'm ruling out this option also. Lymphedema is because of obstruction and fibrosis of the lymphatic channels. So the last question, 65 years old, postmenopausal female presented with the bleeding PV. She undergoes a total hysterectomy. What is the most likely diagnosis? Again, the picture, it is assumed to be endometrial carcinoma. Why we rule out other choices? What is endometriosis? It is the presence of endometrial glands elsewhere in the body is endometriosis. So what are the sites of endometriosis? It can be in the ovary. So if it is in the ovary, we call that as chocolate cyst of the ovary. It can be there in the LSCS scar. It can be there in the pouch of Douglas. It can be anywhere. It can be there in the fallopian tube. It can be there anywhere. That is endometriosis. So endometriosis, a patient will have pain during menstruation in the particular sites where there is a bleeding. So that is ruled out because here we have a postmenopausal female. Fibroid uterus, again, it is ruled out because fibroid uterus will have problem during the reproductive age group. Again, because of hormonal withdrawal in a postmenopausal female, it is not possible. What is adenomyosis? It is the presence of endometrial glands in the myometrium. That is adenomyosis. Again, it will be a problem during menstruation and not in a postmenopausal female. So we are ruling out, and we are left with only one choice, which is endometrial carcinoma, which is the most common cause of postmenopausal bleeding. And that is the reason we do a total hysterectomy in a postmenopausal female. So the probable response for this particular question would be endometrial carcinoma. So with that, we'll complete the recall. Thank you so much.